disease, vestibular problems where you have dizziness or ataxia. Strokes can cause it. Claudication, which is a peripheral neuropathy you want to look at. When you're checking sensory, doing your sensory assessment, you do it throughout the body, because remember, you have your sensory your sensory strip, which is in the parietal lobe, and you have your motor strip. So when you check it, you can check motor to check if that motor, that muscle or that group is functioning motor-wise, and then sensory, that nerves that innervate the sensory aspect. You want to check those too. You're going to check to light touch, so someone should be able to discern if I'm touching you on one area light. Pin prick, if I touch you with a pin, you should be able to feel it. If you're numb in that area, you may not be able to discern light touch and pin prick. Temperature, you should be able to see something cold or hot. Vibration, you can use a tuning fork and put it on top of that person and see how long they can feel the vibration. If it's very short, it may indicate that they have some neuropathy, and they do it a lot on their legs. Proprioception is where you knowing where you are in space and time. So that person, you can take their toe and lift it up. And these are neuropathy patients a lot of times you're doing this with. You lift the toe up and say which direction I have it in, and they should be able to tell you you're holding my toe up or down. And if they can't, then they have some issues with proprioception. Graphesthesia, you can see this a lot with strokes, where I can write a letter in your hand and you should be able to tell me what it is. If you can, that's agraphesthesia, and that usually is corresponding with like a parietal hemisphere stroke. Extinction, a lot of times you see that with right parietal hemisphere stroke. This is like usually an MCA stroke that they have, and what usually happens is you're testing that patient, and you go in to see the patient and you say, do you know where I'm touching you? And they can say yes. When you touch one area, they're able to discern where you're touching them. But then when you test them in the two areas, like you touch them in two places at one time, then a lot of times they can't tell you where you're touching them. So example, I say, Mrs. Smith, where am I touching you? And he says, my right side of my face. And then I go, where am I touching you? He says, actually, this is the right side of my face. And then I say, where am I touching you? He says, the left side of my face. And then you go, where am I touching you now? And he goes, the right side of my face. He's extinguishing the left side, okay? And that's what you see with extinction. Numbness, pins and needles. Remember, if someone has numbness, they can have peripheral neuropathy, so you want to check to see if they have pulses in them. We talked a little bit about delirium and dementia. Remember, dementia is long-term, delirium is transient. Delirium is actually, you see it a lot in your hospitalized patients, and post-surgery, anesthesia, meds can do it, toxic substances can give it, and they have a disorganized thought pattern, disorganized thinking, decrease in level of consciousness, but it's usually transient as opposed to dementia, which is long-term, okay? Dementia, usually they have issues with language, they can't remember words, they have apraxia and agnosia. These are actually things that you want to look for. If they're not able to call words, if they can't calculate anymore, if they can't perform normal tasks like dressing themselves, apraxic, and they can't identify regular objects with visual or sensory, that's an issue. Cognitive, emotional ability, calculation, abstraction, and judgment usually fades away in the long-term dementia patient as opposed to the delirium patient. Again, with dementia, they can actually sometimes, in the early stages at least, they can tell you things that happened years ago. So it's the short-term memory that's gone with them. It's like, what happened, what did you have for breakfast? They won't be able to tell you, but they can tell you things that happened in 1950. As opposed to this person who won't be able to tell you what happened, what they had for breakfast, or what happened in 1950. Again, transient, long-term, okay? The things that can cause dementia, Alzheimer's disease is our number one. Parkinson's disease causes dementia also. Vascular disorders, they can cause stroke-induced dementia. Metabolic disorders, drugs, vitamin B12 12 deficiency is another one that can cause it. Tumors, pressing on different areas in the brain, can actually cause dementias. Tremors, remember, anything that's pathologic is associated with some kind of disease process. Anything that's physiologic is actually induced or you can actually control. Pathologic tremor would be something like Parkinson's. Physiologic tremor could be something like like an essential tremor or something like that you can actually stop. Intentional tremor is what my daughter does when she's sitting in the back of the car and she's just like shaking her leg, and she's just doing that. Choreic tremors associated with Huntington's disease. These are like rhythmic type tremors that you'll see, and a lot of times you can see it too with people who have anterior cerebral artery strokes or ACOM strokes. So the inner aspect of the brain is not perfused. And the choreic movements are like dance-like movements that they'll have with their arms or legs, depending on what's affected. Huntington's is either one. All right. Now we're going to talk about meningeal irritation. When would you see meningeal irritation? Things like meningitis. You'll also see it in things like subarachnoid hemorrhage. Anytime you can have bleeding or anything in the meningeal system that can irritate the brain, and usually it's in the subarachnoid space that you will see it. So subarachnoid hemorrhage, a meningitis will get pus in that arachnoid space, in that subarachnoid space, and can also cause irritation of the brain. Meningeal irritation, you see it. There's a slew of them. They'll call them meningismus. So they have nuchorigidity, so you bend your head and they tell you touch your chin to your chest and they feel pulling or pain. Of course, you're going to take that in context. They have fever and all that with it too, not just pulling and pain. They can have Kernig's or Brudzinski's sign. Kernig's sign, you have the patient lay down in supine, you're going to flex the hip, and then you can re-extend the leg after. So this person, when they flex the hip, they're going to try to extend the leg and won't be able to do it. In this one, they're going to have them lay flat on the bed, and then this person is going to pull that person's head up, and then their legs are going to go from straight to flexed. Okay, and that's Brudzinski's versus Kernig's. You're going to see this. Meningitis, you can see it in encephalitis, you can see it in subarachnoid hemorrhages, okay, in these patients. All right, moving on, cervical radiculopathy, okay. Now, you have your cervical spine, and then you have nerve roots that innervate certain aspect of your body, okay. You have patients who are going to come to you complaining of neck pain, radiating to the arm, or complaining of back pain, radiating to the leg. It's really important for you to know which nerve roots are innervated by what, so you can actually diagnose them properly, okay? It's a really good diagram that actually shows you where is innervated by your nerve roots. Now, a nerve root compression is different than a spinal cord compression. A spinal cord compression will give you absence or decreased ability below the lesion. The nerve root compression will actually just give you restriction on the muscle that's being innervated by that nerve root, okay? And this is looking at nerve root compression. So you have C1, usually you don't have a C1 irritation. C2, you don't really see that either. You can. C3, usually the pain is in the neck area, okay? So they'll have the pain in the neck, and then they'll tell you that it comes like up to the back of their head. So usually it's like here, neck and to the back of the head, C3. Then they have C4. C4 is the shoulders, the scapular and the shoulders across here. Now, the more common ones you'll see are usually lower down. C5, deltoid, okay? C6, bicep, okay? C7, tricep, okay? C8, it comes back down to the back of the hand and comes down to the last two fingers. So when you look at this now, C5, you're going to hold deltoid. C6, bicep, and then C5 comes around, and it can also affect a little bit of the bicep, okay? C6, usually in conjunction with C5, you will have deltoid, and then you can have bicep. But C6 goes all the way down. So it'll come deltoid, bicep, and it'll come down and include these two fingers here. The thumb more so, okay? And then a little bit of that. C7 is usually the tricep, and it'll come in the back here, come down, and it'll do the other half of this finger, and it'll have this other finger here implicated with it, and then part of the ring finger. Then C8, it comes all the way down, and C8 is more medial, so it's more like in towards the body area, and it'll come down, and it'll actually affect the little finger here, okay? So, easy way to remember this, I don't think there's any easy way, but C8, start at the little finger. C7, part of the ring finger and the middle finger. C6, middle finger and part of the index finger, and C7, ring finger and middle finger, and then part of that, and then C6, then the thumb, okay? And then C5 is more deltoid. So you're coming down, okay? You're gonna actually look at the patient. So when we're examining these patients now, how do we know which muscle group is affected, okay? If you have a patient who is having difficulty lifting their arm like this, the deltoid strength is probably weaker. So how are you going to test them? Usually now you're going to do muscle strength. This is where it's important to know that muscle scale, because if you know that muscle scale, then you can actually grade the muscle strength appropriately. So you're going to have this patient, and this person comes in and they're complaining of severe pain that's in that area here. You want to check to see if they have good deltoid strength to indicate maybe there's a C5 cord compression. So you're going to have them pull their arms up, and then you're going to press down on their arms, and they're supposed to be able to resist you. If they can't resist you on one side is weaker than the other, that's probably what's implicated by the C5 nerve compression. Now C6, I'm going to tell you, I'm going to hold my arms like this, and then you're going to try and pull it down. So you're going to apply resistance to the patient's arm, have their arm like this, and you apply resistance. If they can resist you, then they have good bicep strength, okay? Now C7, when I'm checking my tricep strength, I'm going to push down on their arm, and then if I am able to push down, and this is C7 and C8, you can actually check the tricep. You push down, and they're able to resist you when you push down, then you have good tricep strength, okay? So here we have arm abduction, this way. Elbow flexion, this way, that's C6. Wrist extension, I forgot about that. If I pull my hands this way, I'm going to actually, don't let me pull them up, okay? Okay? Wrist flexion is this way, okay? So wrist flexion, so wrist extension, C6, wrist flexion, C7, okay? Elbow extension, the tricep, I should be able to push down, okay? Should be able to push down, okay? And that's your tricep strength. Usually when you implicate C7, usually C7 and C8, usually the disc is between that C7 and C8, so sometimes it could be a C8 and they're having a little bit of pain in the tricep too. So you want to look at that. C8, finger flexion, okay? So you're gonna have finger extensor, okay? And C8, actually have them hold their fingers like this and not let me pull them out, okay? And then T1, T1 is the interosseous muscles. You have to pull my fingers out. Don't let me pull them together. Don't let me pull them together. And that's T1, okay? So this is how you're going to assess them, okay? So arm abduction, deltoid. Elbow flexion, bicep, that's C6. Elbow extension, tricep, C7. Finger flexors, that's C8. Don't let me open them, okay? Keep them together, don't let me open them. And then intraosseous abduction, don't let me pull them together, that's T1. Okay. Increased resistance and spasticity and flaccidity. When you're looking at spasticity and flaccidity, you're looking at upper motor neuron versus lower motor neuron. If your spinal cord is being compressed, you can have upper motor neuron, and you want to look at that. Okay? So this is basically what we just talked about. I want you to review this chart, and it kind of gives you the distribution of what where you're going to have and which nerve root. C4, C5 is usually, if they have a disc at the level of C4, C5, the nerve root that's going to be compressed is the C5 nerve root. If you have a disc at the level of C5, C6, the C6 nerve root is going to be compressed. If you have a disc at the level of C6, C7, the C7 nerve root is compressed. And C7 to T1 is the C8 nerve root that's being compressed. Okay? And you'll have all these, how you can examine them here. Okay? The lumbar now, somebody comes in with back pain. Okay? And if it's just in the back, sometimes it's a lot, it's muscular. When it's radiated down to the leg, that's just like it's radiated in the arm with the cervical, we call that radiculopathy. And when you have radiculopathy, it usually means that there's a nerve root that's being compressed. Same concept with cervical. I didn't say it, but same concept with cervical. When you're looking at your lumbar, I want you to do this. Just take your hand, put it on your thigh, okay? When you put it on your thigh, I hope you can see me from the camera here. So when you put your hand on your thigh, your thumb should be pointing towards your groin. Your index finger should be pointing more your inner thigh. Your middle finger should be on your top of your thigh. Your ring finger on the almost the top of your thigh, but more to lateral. The pinky should be lateral aspect of your thigh. And then you have normal fingers, okay? And then the back is something else. So I want you to look at this. L1 should be pointing towards your thigh, your groin. So if you have an L1 nerve root compression, your pain should be in your groin area, numbness and tingling groin area, okay? If you have an L2, where your hand is, it's going to be on the inner thigh, okay? So the pain and the numbness is going to be in the inner thigh area, okay? L3 is going to come down on your anterior thigh and come almost on the inner thigh area. L4 is going to come down on your anterior thigh, doesn't go out all the way lateral, comes down above the knee and kind of stops right there at the, a little bit below the knee area. L5, okay, it comes down lateral, so your pinky finger, lateral all the way down. And L5, it goes laterally, and then it goes to the top of the foot. So the top of the foot, see, it comes down laterally, and then to the top of the foot. So a lot of times your extensor hallucis longus muscle, which actually innervates the big toe, is implicated with L5 nerve root compression. And then S1, remember we said we didn't have any more fingers. It's the posterior aspect of the leg and comes all the way down to the lateral aspect of the foot, just with the pinky toe involved, if you look at it here, okay? So that's what you're gonna do. Now testing it, okay, so L1, L2, and 3, you're gonna all do hip flexor. So if hip flexor, I should be able to lift my leg up, and that's your iliopsoas muscle that actually helps you to lift your leg up, okay? Then you have L2, L3, L4, knee extension, which is your quadricep muscle. So if I hold the leg up and ask them to kick out, and I hold resistance when they're trying to kick out, if they can actually push me with a lot of resistance, then I know that the quadricep muscle is intact, okay? And that's L2, L3, and L4. L4, foot dorsiflexion, and that's anterior tibialis, okay? And that's actually, if I pull my foot back, I should be able to pull it back with good strength, okay? Dorsiflexion is flexing the foot back. L5, great toe dorsiflexion, and that's your extensor hallucis longus, okay? And that's a big toe, being able to flex your big toe back against resistance. S1 is your hamstring. Remember we said knee extension is kicking out, that's your quadricep. So now if I tell you to let me bend your knee and don't let me pull it out, then that's your hamstring muscle that we're testing on there. And that's testing gastrocnemius, okay? Actually, that's testing your hamstring with your knee flexion. That's testing S1. And then S1 and S2 is your gastrocnemius, which is take your foot and put it on the pedal, okay? So plantar flexion. So I'm going to take my foot, tell them to push like they're stepping on the gas pedal, okay? And that's implicated with S1. Okay? So, very important, again, these are your myotomes or dermatomes that are associated with the nerve roots. Now what we're moving on to, if there's a spinal cord lesion. Remember, spinal cord lesion, there will be weakness or paralysis below the level of the lesion, okay? Anything above C4, it's usually your diaphragmatic muscles are implicated, and this person probably needs a trach and permanent respiratory support, okay? C5, spastic paralysis of the trunk, arm and legs. This is a quadriparetic also. C6, C5, C6, again, almost quadriparetic. C8, spastic paralysis of the trunk, arm, hand weakness only. Still, they may be able to lift a little bit of their arms, but still not much function, and it's really like above. Okay. T1, paralysis of the trunk and legs, okay? And then T11 to T12, paralysis of the trunk and legs, also. L1 to S1, flaccid paralysis of the legs, okay? If you notice now, we went from spastic to flaccid. Why we go from spastic to flaccid? Because where does your spinal cord stop? Your spinal cord stops at the level of L1. L1. So between L1 and 2 is where your spinal cord stops. We said upper motor neuron give you spasticity, right? And lower motor neuron, which is your nerve roots, going to give you flaccidity. So L1 to S1, you have flaccid paralysis because now we're dealing with the nerve root, what we call the chorda equina. The last part of the spinal cord ends, the conus medullaris is the end of the spinal cord, and then after that is just a whole bunch of nerve roots that goes down and innervate the lower part of the legs, and that's what we call the chorda equina. Those nerve roots are what we call horsetail that comes down, okay? Reflexes. We're going to actually do the reflexes during your competency examination. And remember, you have your bicep, your tricep, your brachioradialis, your knee jerk, your ankle jerk. These are all your reflexes that we're checking. Remember, reflexes are primitive, okay? This does not require any function or brain function to have reflexes. Compression of these can give you either spasticity or flaccidity. Absence of reflexes means peripheral nerve roots are being compressed. Compression of spastic reflexes can mean that you have spinal cord compression. Okay? Grading of reflexes, you have 0 to 4. 4 is hyperactive, 0 is no response. Okay? And most people are at around a 2. Okay? If you're at hyper active, that usually indicates that there's some kind of compression. But some people, generally women, are a little bit hyperreflexive and can hang out anywhere around 3, or maybe, not 4, but maybe around 3. Okay? Abnormal reflexes. Abnormal reflexes can mean that there's myelopathy, or that means that the cord is being compromised in some way. Okay? You have the clonus. Clonus is usually, how do you test clonus? Is you have the patient, you put their foot against your hand, And the foot, if they have clonus, will beat like this, will have several beats. And that usually indicates that there's spinal cord injury. The plantar reflex, which is the Babinski, we know that this is normal in kids, it's a primitive reflex, but in adults, usually means that there is some kind of abnormal brain issue, brain compression or something like that. The Chaddock sign is big toe dorsiflexion. When you stroke the lateral aspect of the foot, again, means that there's some corticospinal tract damage. Corneal reflex usually means that there's brainstem damage. Gag reflex, absent, usually means there's brain damage. Anal wink, usually you strike the back of the anus and then the anus, what do you call it, contracts, and that usually is implicated when there's a nerve root compression. Lermit's sign is a shock-like sensation that occurs during flexion of the neck, and now you see that a lot in people with multiple sclerosis. Abdominal reflex, or you're stroking the abdomen and you can see the area around the umbilicus contract, and you can see that in spinal cord compression. And chemostatic reflexes is directly stroking the medial aspect of the inner thigh, and you can see the scrotum sac contract, and that usually is spinal nerve root compression also. Okay, so which reflex is going to be implicated with what? Your bicep, if you have an absent bicep reflex, either the C5 or C6 nerve root is being compressed. If you have an absent brachioradialis, it could be C6, C7, or C8. You have an absent tricep, it's usually C6 or C7. Hoffman's, I didn't have it on the other slide, but it can be. Hoffman's is usually you take the fingers, and what you're going to do is you're going to hold the fingers with the hand completely relaxed, and you're supposed to flick the finger. And if someone has a positive Hoffman's, when you flick the finger, their whole hand kind of contracts. And that usually indicates that there's some spinal cord compression. Okay? And spinal cord compression is usually at C6, C7, or C8. Okay? Or it could be above it. Patellar the patellar root reflex, or you can see an absent patella, usually L2, L3, or L4. Achilles, meaning the ankle jerk. You strike the ankle and your foot should jump. If that's absent, usually means that there's S1 or S2 nerve root compression. Okay? And the anal wink, again, S4 and S5. How you record your reflexes? Usually they recommend you draw it out, but you can just put +2, +3, +4, whatever you see. Again, symptoms of myelopathy, depending on where in the spinal cord it's being compressed, depending on what you're looking at. Limit sign electrical shock, you can see that with patients with multiple sclerosis, myelin sheath issues, muscle wasting because of lack of movement. They can have spasticity, rigidity. All these can be associated with myelopathy. Very important for you to remember a quarter equine syndrome. We see that a lot in clinical practice. Someone has a humongous herniated disc, and the humongous herniated disc is compressing at L3, and all the nerve roots at L3 are being strangled. Well, the nerve roots come down and they innervate the bowel and bladder. So if those nerve roots are significantly, compressed, they cannot innervate the bowel and bladder. And what usually happens is these patients end up with a full bladder, not able to urinate, a full bowel, not able to evacuate their bowel. And if this is not corrected emergently, they can have permanent damage. So this is actually a surgical emergency. Someone comes in with a large herniated disc, complaining of back pain, radiating down the leg, and they tell you, I haven't peed in 2 days, or I haven't pooped in 2 days. These patients, you need to be, wow, emergent neurosurgical evaluation, or emergent MRI, so that you can actually get to see the structural lesion. Quarter equine is a structural diagnosis. So if someone comes in and they tell you, I can't pee or poop, and I haven't been able to do it in the last 2 hours, and then you do an MRI and there's nothing there, then it is likely not called equine syndrome, because they have to have a disc actually compressing the nerve root. Okay? And remember, some people are going to come in with symptoms without pain. Remember, we said that an MI, a silent MI, is very applicable in patients with diabetes. Same thing here. We actually had a patient who his only symptom was that he was having trouble evacuating his bowels. Having trouble evacuating his bowels, he went to another hospital, they did laxatives, sent him home with these laxatives, but he was still having the issues. He now was not complaining of back pain. He ended up coming to our facility after, and he was complaining of really severe constipation. He hadn't gone in a few days, and then he remembered that he hadn't voided. So the ER physician ordered a CT of the abdomen. When he ordered a CT of the abdomen, he saw his bladder is tremendously distended, had a whole lot of urine in it. They called and got a stat image of his back, and he did have a large herniated disc, but he wasn't complaining of back pain, so it is possible. Okay. All right, so now we're going to go to differential diagnosis. We already talked about the exams, how we're going to look at it, different disease processes. Stroke, one of the most common neurological illnesses. We have ischemic versus hemorrhagic. Ischemic, not enough blood on the brain. That means there's a clot or something that's stopping blood from going to the brain. Or we can have hemorrhagic, where there's too much blood on the brain. They have a vessel that's ruptured and causing too much blood on the brain. Okay, we have thrombotic versus embolic. Thrombotic usually means that there is a thrombus formation. Usually it's clot on plaque. Remember, plaque is not discriminatory. It doesn't just go to the heart, also goes to the brain. Okay, and if you have a person who has really significant hyperlipidemia, they have significant heart disease, they probably have plaque buildup in the cerebral vessels also. And what usually happens, you have a rupture of a plaque, and it goes and it clots off that area that was once open, and you end up with thrombotic stroke. Okay, already narrowed vessels. Embolic stroke usually means that there's a clot coming from somewhere else, usually the heart. A lot of times you see it in patients with atrial fibrillation. It can also be in patients with a lesion on the valve, okay? Endocarditis, they can send shower of emboli to the brain, okay? Small artery occlusion, lacuna infarcts, usually you see this with hypertension, and these perforating small vessels in the brain. You see them a lot in the basal ganglia, the thalamus. These are small vessels, and they get occluded, long-standing hypertension, hypertrophy, fibrosis, and you can get strokes through them. Cryptogenic usually means that we don't know why. Now they're finding out that a lot of times these patients come in with these strokes, and we used to call them cryptogenic in the past, but now they're putting loop recorders in and finding out that these people have proximal atrial fibrillation. You know, it just didn't happen when they were in the hospital, but that's what caused the clot. Things